This episode of The Benefit Whisper is brought to you by Route 3 Insurance and Financial Services, where smarter benefits begin. If you're tired of rising healthcare costs and opaque insurance contracts, Route 3 is here to help you take control. They specialize in transparent, employer-driven benefit strategies that protect your people and your bottom line. Ready to break away from the status quo? Visit www.fixmybenefitsnow.com and discover how Route 3 can help you build a plan that actually works for your team and for your budget. Welcome to another episode of The Benefit Whisper. I'm your host, Ralph Weber. You know, I've always said that healthcare is a system full of smart people trapped inside bad contracts. That's exactly what today's conversation is about. The world of contract standardization, algorithms, and productivity. I spoke to Ann Lewandowski last week about this. So there are a lot of people that are talking about this. Today, my guest is a return guest, a fabulous guest. Dr. David Scheinker is the executive director at Stanford Children's Health. He's also the founder and director of SURF Stanford Medicine, a research lab that is applying operations research and systems engineering to healthcare delivery. David's work bridges two really powerful ideas. Number one, how we can standardize contracts and algorithms to make healthcare more fair and more efficient, and how hospitals can take a page from industries such as aviation, using optimization models to improve scheduling, staffing, and productivity. And that's what we're here to talk about today. So, David, for those that don't know you, do you want to tell us a little bit about yourself?
Thank you. A pleasure to be back on your show. I actually studied theoretical math and started my career as a research mathematician for a few years before I transitioned to healthcare operations and engineering. Now I've been at Stanford for just over 10 years. And at the Stanford Children's Hospital, my primary focus is how do we improve the quality of the care? How do we reduce the cost of the care and improve the experience of our workforce? I now have two young daughters, both born at Stanford Children's. And so the work about which I've always been passionate is even more personal.
Yeah, no, absolutely. You know, and children's hospitals are amazing. I mean, they do so much. Children are the most vulnerable population. But I remember many years ago, David, I had a friend of mine who's passed away since, Dr. Marius Barnard. He and his brother Christian performed the first successful heart-to-heart transplant in 1967. He always said, first, do no harm includes financial harm. If you cure a patient, but you bankrupt their family, then you have done them harm. So I think that's a huge issue in the US. Every minute there's a family that declares bankruptcy due to medical bills. So it's definitely a huge area that we have to work on. And all of the anger with the healthcare companies is just really getting to a head. So I think we're in a time where this needs to be brought out. Tell me a little bit about the lack of standardization. How does it create waste and misaligned incentives?
Well, so I'll just mention that there's the extreme of people being bankrupt by medical debt, but there's also the far more common and still deeply problematic uncertainty about so many things about your experience in the hospital. Whenever you're in the hospital with a child, you're probably terrified. It's probably, one of the worst experiences, most stressful ones of your life. Yeah. And as an institution, you strive to provide the best care and support the family. Right. And part of that support is, as much as possible, transparency. Transparency around when you can expect your child to leave the ICU and go to acute care, when their breathing tube can be removed, when you can get them back home with their family. And one of my colleagues, he's the medical director of my group with a fantastic team, Dr. Andy Shin, he created this program called Target-Based Care that for a large class of heart surgery procedures would identify as soon as the patient gets to the hospital when you expect them to be ready to take out their breathing tube, when you expect them to leave the ICU, when you expect them to leave the acute care and go home. It's been a fantastic success. But early on, one of the major challenges was that this kind of standardization and improvement led to patients having shorter, more predictable lengths of stay, which is great, right?
Yeah.
Unless you're concerned that you are not going to be paid as much for these kids. because the way the contracts with the insurance work is if you spend all of this institutional time, money, and effort to
Hmm.
standardize and improve care, that translates directly into lost revenue.
Right.
Now, to the credit of Andy and his team and our institutional leadership, the program received support. They said our first focus is to do what's right for the child. And since
Hmm.
target-based care has been expanded to many services, many procedures, and produced fantastic results. But I think it's a perfect example of a clear misalignment that's purely contractual. In a better
Right.
contract, we would make more money by
Hmm.
providing this more efficient care with fewer days, and
Right.
the insurance company would save money. Every
Right.
time you cut off days in a cardiovascular pediatric intensive care unit, that's
Hmm.
thousands of dollars that can be
Sure.
split as
Hmm.
shared savings. But that's not how contracts work, nor is there any clear path to negotiate those kinds of contracts with insurers.
Wow, that's really unfortunate because when money comes before care, people suffer, financially, medically. It's just not a good situation. So, David, if you were designing hospital or payer contracts from scratch, what data would you use to anchor them on?
Our team of students in a project with Kevin Schulman, my collaborator, that's really been a national leader in this work, has actually gotten a sample contract from a large health system, and we've broken it down to its components.
Hmm.
There's typical things. What should be covered? What shouldn't be covered? What are
Hmm.
the different rules for different payment rates based on if it's outpatient or inpatient? There are, about 20 categories of major clauses in these contracts.
Hmm.
And then in each of those categories, there may be some specific distinctions that need to be made, like inpatient versus outpatient.
Hmm.
But all of that seems totally unnecessarily complex when it lives
Right.
as a 30, 40, 150-page PDF document. In
Hmm.
reality, what it could and should be is digital,
Hmm.
and each of these common clauses, like how much are different things paid for as a function of where are they provided, do they require anesthesia or not,
Hmm.
those can be like Lego building blocks. And there can be this giant box of digital Legos
Right.
that whenever a insurance company and a hospital want to build their contract, they can pick the different Legos they want.
Hmm.
They know that every single type of Lego is in there. They know that they can choose the color or the number of rows in the Legos.
Right.
And then the contract gets put together. Maybe it's exactly the same contract they have now.
Hmm.
Maybe by going through this process rigorously and systematically, they realize there's a bunch of other things that can be done in the contract to improve
Right.
its value for both parties. But whatever you do, it's made out of systematic building blocks
Okay.
and it's digital. So
Right.
then there's no ambiguity, there's no question. It can be adjudicated potentially mostly algorithmically.
Hmm.
And if you want to examine, okay, how could we change it? For example, you're going to say, you've got this fantastic program, you're going to reduce post cardiac surgery length of stay.
Hmm.
How should we can't change this contract? Well, any particular change you want to evaluate its impact on the insurance company and the hospital, when the contract is digital, it's kind of trivial. It's like, this is how long patients stayed last year.
Hmm.
You know, assume 1 out of 3 patients stays 2 fewer days and half the patients stay 1 fewer day.
Right.
Here's exactly how the new contract shakes out. And a computer can tell you that instantly instead of it being some inscrutable mystery that both sides have to fear all sorts of uncertainty and risk about.
Makes perfect sense. Years ago, I was talking to CMMI, and they were looking at a different payment system for Medicare. And at that time, they told me that their programs are still programmed in COBOL. So there are a bunch of legacy.
Stable, very secure and reliable.
Yes, yes. It reminds me of a story. There was this young girl and her mother. They were making Thanksgiving dinner, and the mother cuts the turkey in half. And the girl says, "Mom, why did you cut it in half?" She said, "Well, that's how I was taught to make turkey. Let's ask my mom." So they asked her mom, "Mom, how come you taught me how to make turkey by cutting in half?" And she said, "Well, that's how my mother taught me." So they called the assisted living facility, great grandma, and they said, "Why do you cut the turkey in half?" And she said, because in the 40s and 50s, we had tiny little stoves and the big turkeys didn't fit. And that's one of my favorite examples of we've always done it that way. Healthcare is different. So, at one time it didn't fit, but now we have all of these tools that we can use. And we have different people than the baby boomers that are more in control of the system, that know about transparency, expect transparency. And these definitely could be streamlined. I'm sorry to go on, but I'm just really passionate about this.
Well, so I think your example is fantastic and captures part of it. I like that
Hmm.
joke as well. But I think there's another part that it kind of leaves out that paints an overly optimistic picture.
Hmm.
There's a reason that most insurance markets in the US, as measured annually by the American Medical Association, become more and more concentrated.
Okay.
There's not an increase in competition.
Mm.
And there's very high profits associated with being one of these few insurers that has these types of market dominance. And so I think the fact that the current contracting is so bespoke and complex and inscrutable, it's a very effective moat against competitors entering the insurance market. If insurance contracts were all these kind of digital Lego building block, then that would open the door to so much innovation. You wouldn't
Yes.
have to spend your entire time building up the capacity to navigate this thicket of state and local and federal regulations and hospital negotiating tactics.
Mm.
You would have to spend almost no time on that once digitized, and you could spend all of your time innovating on how to generate value for the patients, the
Right.
hospitals, the insurers, the employers together. But innovation is hard. I mean,
Yeah.
the Nobel Prize in economics just went to the economists that described destructive innovation, new firms overtaking others. Well, if you're an incumbent firm and you have some way to kill innovation in the space
Mhm.
to prevent younger, more agile, more dynamic firms from taking away your profitability, you would be crazy not to do everything you could to kill that kind of innovation and
Right.
prevent it from happening.
Yeah, that's unfortunate, but you're right. You're absolutely right. So tell me, David, what can healthcare learn from industries such as finance or logistics that already use automated contracting and validation? What can healthcare learn from that industry?
I mean, I think what healthcare can mostly see is the huge benefits those industries reap
Mm.
and use that as a motivation to pursue this more aggressively. In any
Right.
kind of big industry, any big movement, there's only enough space for a few major efforts that people are pushing towards and putting their energy behind.
Hmm.
I strongly believe this should be one of the top three.
Right.
Another example is something that Barack Richmond, one of my colleagues and also a healthcare attorney, Kevin Shulman and I, we've published about swaps. Used to be these contracts for financial instruments. They used to
Right.
be $100,000 contracts, each one written between two parties with a massive time consuming team of attorneys and
Hmm.
financial analysts. And they standardized it. They created this huge way of making it the standard code of swaps, a $5,000 relatively quick, short process. It's a great illustration of that's one of the few industries that in some ways is even more complex than healthcare and handles bigger sums of money than healthcare, but
Wow.
has shown that, it's possible. And then again, everybody benefits when the contracting costs that are just otherwise extracted from the system come down.
Yeah, absolutely. The last time that you were on, David, you talked about the waste as a percentage of the healthcare spend. What was that number? I think you said 20% conservatively.
So healthcare administration,
Hmm.
billing and insurance related costs widely, including Medicare, Medicaid, and
Hmm.
private payers, that's about 30%. So the
Wow.
projections of total healthcare expenditure being a little over 5 trillion, that's about 1.7 trillion.
$1.7 trillion every year
Yeah.
could
So
be
that's the
saved.
spending. That's not the waste.
That's the spending. Okay.
That's the
Okay.
spend. So now there's
Okay.
two different ways to look at it.
Right.
How much of that is just total waste?
Right.
Inefficient processes, error, fraud, abuse, and that whole spectrum.
Hmm. Right.
Estimates put that at around $400 billion a year.
Okay.
Now, the question that I think is more interesting and more relevant is how much of that could potentially be saved
Hmm.
if you went to a digital standardized system. And those are the savings that I argue, based on a lot of kind of rigorous research we've done, and then, of course, reasonable estimates, those are the savings that are approximately $1 trillion a year.
Wow. So of the 1.7, you're saying you think we could save $1 trillion a year. Wow, that's amazing. It's so much waste, and so many fewer families would struggle paying healthcare costs. Employers could spend more on the employees instead of their healthcare. Nothing but good results. But it seems that like there are too many middlemen in the picture that benefit from all of this waste.
Yeah. I mean, every time there's complexity and opacity, people
Mm,
who make it their career to understand it and game it can profit. And they
right.
do. I mean, that's kind of built into capitalism.
Yeah.
And unfortunately, I think the costs to the system are much higher
Hmm.
than just the excess profits that PBMs make. Or in your last episode with
Hmm.
Ann Lewandowski, you
Right.
discussed these kinds of like misaligned incentives that
Right.
brokers have,
Yeah.
because to facilitate those kinds of, let's say, problematic profit streams,
Right.
they maintain this huge thicket of complexity. But
Hmm.
that thicket of complexity imposes tons of other costs on patients, families,
Sure.
providers, and insurers that aren't even profiting these people. They're just
Hmm.
kind of built into the system to benefit the incumbents.
Wow. Wow. Okay. Yeah, no, I totally get that. My book was entitled, my last book, which I need to update, was called Rigged: How Insurance Ruined Healthcare. And I still believe that insurance ruined healthcare with all of its complexity. I mean, insurance is necessary. We all know that, but it doesn't have to be so complicated. My background, as you probably remember, I was an air traffic controller and commercial pilot way back. So I always like to think about healthcare, from that realm. When I was an air traffic controller, you could have up to 50 aircraft going different directions, different speeds, different altitudes. The wind speed affected it, the weather, the turbulence, all of that stuff. And, I can visualize it that way. So now the same tools that the airlines use to map flight routes and schedule crews, that could definitely help hospitals run more efficiently, don't you think? What would that actually look like in practice?
Absolutely. Yeah, there's something I'm actually working on a little bit of research on right now. But from 1995 to 2019, aviation labor productivity increased by about 250%, and their overall costs in real inflation adjusted dollars declined about 28%. And that's all while fuel prices went up. In the same time, labor productivity was essentially flat,
Mhm.
and total hospital costs increased by almost 800% in real dollars.
Wow.
So I think that a lot of the operations tools that aviation uses, for
Mhm.
example, there's a type of optimization called integer programming that helps you make better crew to plane assignments that
Right.
minimize costs, minimize overtime, improve employee satisfaction by giving them more predictable schedules that they ask for.
Right.
Or the same kind of optimization, but slightly differently, can be applied to figuring out, okay, you have an idea of which people want to fly from where to where,
Mhm.
but there are billions or trillions of potential ways that you can organize planes to go from San Diego to Las Vegas to Salt Lake
Sure.
City or the other way
Yeah.
around. So these kinds of flight rep map optimizations. In healthcare, there are direct analogs. The way you staff nurses to units while trying to account for demand that varies both seasonally. You get a lot more elective pediatric surgery in the summer when kids won't miss school. You
Mhm.
get a lot more skiing injuries in the
Sure.
winter.
Yep. Yeah.
You have also important quality and safety concerns in really complex units. You want to make sure that the nurses with the specific skills to care for the kids on that unit are going to be available. For example,
Right.
there's something called like a VAD. It's essentially an external harp that a kid can pull around with a little wagon behind them. That
Mhm.
requires specialty nursing care to make sure that that kid is doing okay with that.
Mhm.
Hospitals, though, don't use these types of technologies much. And then
Right.
similarly to the kind of the designing the routes between cities, hospitals
Mhm.
usually assign services to units. So for
Mhm.
example, neurology and neurosurgery will be in, you know, unit 100. And
Mhm.
orthopedic surgery and cardiology will be in units 200 and 300 and so on.
Right.
You can also try to optimize how services are assigned to units to best balance how many patients those services see with the number of beds available in those units.
Mhm.
A lot of these things could be deployed in hospitals to improve quality, reduce costs, and reduce some of the stresses that nurses and physicians are experiencing that lead to burnout. But
Sure.
some of them, it's just a matter of us needing to improve our culture and improve our focus on operations. But a lot of it, again, is made more difficult by everything we do having these uncertain potential impacts on revenue
Mhm.
and potential loss of revenue if, the way you organize your patients reduces length of stay or reduces days in the
Right.
ICU.
Right.
Of course, when it's clinically appropriate, we can do it, but it's much harder to ask the CFO or the CEO of an institution, can you invest in dollars in this kind of significant operational change that poses risks and challenges? And the best we can tell, we might lose $2 million dollars a year because of it or save $2 million dollars a year. We don't know.
Right.
That
Right.
level of uncertainty that comes from the contracting is just another barrier to this kind of standardization and optimization.
Yeah, no, absolutely. I heard a couple of years ago, I forget the numbers, but I heard that Amazon was hiring something like 150 PhD economists every year or something to that effect. Now, Amazon has very efficient things in place. You can see how many stops away your delivery is. You can get a lot of things the same day. They've just made it so efficient. And while healthcare, as you said, 800% loss there in terms of becoming less effective, less efficient over the years, while somebody like Amazon has done much better. We're working on a payment system that pays at the time of service, 100% of the cost, both from the plan, the benefit plan, and from the patient, so that the hospitals, who have really, in essence, become collection agencies, don't have to do that because they're not collection agencies, but they're being forced to be collection agencies for the insurance company. And they end up getting just, a fraction of the cost. So we've already talked about why they're slow to adopt. Are there any pilot programs or case studies where hospitals have used these kinds of methods successfully?
You know, that's a great question. I know we've tried different things to kind of optimize billing, and our CEO told me that he's had conversations with the leadership of major insurance companies
Mhm.
exactly about this. Can we end the arms race? Can
Wow.
we agree on our side to submit clean, specified exactly the way you want them,
Mhm.
bills and documentation of care, and then you pay them immediately and we don't need to each invest in these thickets of middlemen and AI companies and other
Right, right.
denial and counter denial technologies. So for us, that's clearly a value proposition. In that
Mhm.
particular story, that conversation, unfortunately, didn't lead to it happening.
Mhm.
And again, I think it's because the insurers have very strong disincentives
Yeah.
across any reduction to the complexity that protects them from competition.
Right, right. Well, when you think about it, if you think about that 1 trillion that could be saved, that approximately 20%, if the healthcare revenues went down by 20%, let's say their profit was the same or better, okay? I think that would affect stock prices, and that might be what they're afraid of.
Yeah, it's funny. One of the very first papers Kevin Schulman, Arnold Milstein, and I published about this actually appeared
Mhm.
in JAMA. We laid out exactly this argument that although insurance companies are in theory supposed to be the intermediaries that
Mhm.
negotiate costs down and control costs, if
Right.
you project out their expected stock price, let's say as a fixed ratio of the price to earnings ratio,
Mhm.
then, if healthcare spending ever slows or goes down, their stock prices plummet.
Right, right. I just remembered what you were talking about a couple of minutes ago about procedures being done in the summer. The other thing in non-children environments is the end of the year when people have used up their annual deductible. They're through their deductible. So that's the busiest time of year for hospitals. I've seen plans that have a monthly deductible that is a fraction of the annual, not 1/12, but it's a fraction of that allowable, and it spreads things out. It really gets people to get care when they need it. So ideas like that, they're innovative, but they're also slow to adopt.
Exactly. And, if every digital contract was made up of these Legos and there was
Mhm.
one Lego that said, okay, here's how your deductible works. And then
Right.
people realized, oh, wow, what a smart deductible. And all you had to do
Yeah.
was go in and mutually agree on changing the Lego from an annual deductible to a monthly deductible.
Right.
Then, like these kinds of innovations could propagate through the system to benefit people much more quickly.
Yeah, absolutely. There really, really are so many. So, David, another thing, we hear all about AI. And, to some people it's scary. Is it going to replace people? Are there leaks of information, et cetera? Is it HIPAA compliant? Is HIPAA enough? There's all this stuff. So LLMs, how could they change things for the good?
That's a fantastic question. I have in some cases been skeptical about LLMs
Hmm.
and this idea that they're going to replace physicians and nurses altogether. Most recently, if you ask GPT, is there a seahorse emoji? It goes totally insane and gives you a 7-page rant. And in general, I'm
Uh,
reassured by examples that demonstrate that these things don't think, and
right.
we are nowhere near ready trusting them the way we trust our physicians.
Sure.
But there are, I think, a few great uses. I have a
Hmm.
fantastic graduate student, recently graduated, Aya, that used LLMs to help her read through the provider manuals of
Hmm.
4 large insurance companies and
Okay.
abstract all of their content on prior authorization into these digital building block contracts. So
Hmm.
we've actually done that for prior authorization with one graduate student, albeit brilliant, working part time. Closely related to that, I have a group of students that's designed an integer program for helping our hospital figure out how to best assign services to units. And
Hmm.
now what we're doing is building an LLM that can help the hospital decision makers interface with that optimization directly instead of needing to set a meeting or go back and forth by email with my graduate students. So I think by both translating these 300-page plus complex contracts
Hmm.
into a digital format and by kind of democratizing previously really specialized optimization technologies so that more hospital stakeholders could use them directly,
Right.
LLMs as kind of intermediate technical tools have a lot of potential.
Wow, that's great. That's great. I love that. And I'm not an AI expert by any stretch of the imagination, but I can definitely see that. It makes so much sense, but there is so much fear. So hopefully we start getting some of that optimization because we really do need to fix this issue as we talked about. So anyway, David, we could go on for a long time, but we're coming up to the end of our time. So this has been a fascinating look at how the same math that keeps airplanes on time could make healthcare more efficient and equitable. So before we wrap up, how can listeners follow your work or get in touch with you?
It's been a pleasure to chat with you. Listeners can go to my website, surf.stanford.edu, to find my contact information or publications. Could find me on LinkedIn by searching my name. I'm lucky to have an uncommon, easily Googleable name.
Yes, absolutely. Nice German name with the SCH.
German Jewish, yeah.
Yeah. So great. And as always, for my listeners, if you'd like to learn how we can help employers or how we can cut waste and regain control of their healthcare spend, visit fixmybenefitsnow.com or email me directly at Ralph at the Benefit Whisperer. I'm Ralph Weber. And if this episode benefited you, please share, like, subscribe. And thanks for listening to the Benefit Whisperer. And thanks,
Thank you
David,
for
for
having
being
me.
here.
Thank you for having me.